Welcome back to the Deep Dive, where we take the densest, most high-stakes knowledge and transform it into the critical insights you need to master your field.
Hello again.
Today, we are undertaking a deep dive into what is arguably one of the most foundational yet incredibly complex clinical syndromes you will ever encounter in medicine. We are talking about diabetes mellitus.
And we've distilled this dive from a really highly respected source, the comprehensive medical textbook, Davidson's Medicine. Our mission today is, I think, very clear and very targeted. We want to build a robust, structured, and, most importantly, memorable clinical framework for you.
Especially for you, the learner.
Exactly. Guiding you through the epidemiology, the core beta cell physiology, the diagnostic toolkit, those life-threatening acute crises, and then the nuances of modern management.
Think of this as your essential survival guide, really, for exams and for clinical rounds.
It is.
And the gravity of the subject, it just can't be overstated. This isn't just a disease. We are looking at a true global public health crisis. Let's start with just the sheer scale of it. In 2019, the global tally showed 537 million people living with diabetes.
537 million. It's a number that's almost hard to comprehend. That's over 9% of the entire adult population of the planet.
Wow.
And that massive number alone is, sobering. But the composition of that number is equally critical for context. We have to remember that about 90% of those cases are type 2 diabetes.
Right, so it's overwhelmingly type 2.
It is. And that's the form that's driven largely by lifestyle and environment, which is, of course, why the epidemic continues to accelerate so frighteningly.
And the financial cost, it almost defies comprehension. These numbers aren't just statistics on a page. They represent a fundamental crushing strain on healthcare systems everywhere.
And the projections show the prevalence hitting 700 million by 2045.
700 million. So what about the immediate financial impact right now?
Well, in 2017 alone, the estimated global healthcare expenditure that was directly attributed to managing diabetes, and this includes treating its, countless complications, was a staggering 727 billion US dollars.
Billion. With a B.
With a B. And think about what that means. That one single disease accounted for 10% of total global healthcare spending that year.
That's why this matters so much.
That's exactly why. It's why every single medical specialty, from cardiology to ophthalmology to nephrology, is forced to confront diabetes every single day. The financial and the human burdens are, they're just inextricably linked.
Okay, so let's start our exploration by looking at that global footprint. When we analyze the prevalence geographically, the distribution is anything but random.
Not at all.
What are the regional hotspots and the low points? What does this distribution tell us about the underlying drivers of the disease?
The regional variation is really striking. Our sources highlight a pretty significant and, frankly, worrying concentration of the disease in the Middle East and North Africa.
The MENA region.
Exactly, the MENA region. In 2019, the prevalence there was 12.2%, which was already the highest globally, and it is projected to jump to almost 14% by 2045.
And where's the lowest?
Conversely, some of the lowest prevalence rates are found across the African continent, though, this is changing very rapidly with urbanization.
This pattern immediately suggests a really deep link to economic development and societal shifts, right? Especially when we start to differentiate between type 2 and type 1.
100%.
Let's isolate the drivers for type 2 first.
So type 2 is fundamentally an environmental and societal condition meeting a genetic predisposition. That's the key.
Right.
Its prevalence is very strongly correlated with rapid urbanization, increasingly sedentary lifestyles, high-calorie, highly processed diets, and, of course, the associated rise in obesity.
And we see this almost in a natural experiment with migrant population.
You do. It's a powerful demonstration. You see individuals moving from low-income agrarian settings to industrialized, westernized countries, and they often see their risk of type 2 diabetes just surge, sometimes within a single generation, as their entire environment changes so radically.
That makes the link just undeniable. And the fact that we're now increasingly seeing type 2 in younger demographics, even in children and adolescents, is profoundly worrying.
It is. It's one of the most alarming trends. And the data shows this rise is most pronounced among specific ethnic groups in high-income countries.
And says
We're talking about Hispanic, non-Hispanic, Black, and South Asian youth. This really indicates that a combination of specific genetic susceptibility is encountering an increasingly toxic obesogenic environment much, much earlier in life.
But type 1 diabetes tells a completely different geographical story. It doesn't seem to follow wealth or urbanization at all.
No, it's a totally different map.
So what is that strange geographical pattern we need to remember?
Type 1 diabetes, which is the autoimmune form, has this fascinating cold weather correlation.
The cold weather.
Yeah. It is significantly more prevalent in countries closer to the polar regions. Finland, for example, has one of the highest incidences in the world. We're talking over 60 new cases per 100,000 population per year.
Wow, and you compare that to...
You contrast that with regions like China or India, where the incidence can be as low as 1.1 per 100,000. It's also much more common in people of European descent.
And there's that intriguing seasonal pattern you mentioned before.
Yes. For reasons that are still, not well understood, the peak incidence of a new type 1 diagnosis mysteriously occurs during the winter months.
So what does that tell us?
Well, this strong geographical and seasonal clustering provides a really clear epidemiological hint. The triggers are likely not lifestyle-based, but rooted in things like infections or other environmental factors that precipitate that underlying autoimmune destruction.
Okay, so let's pivot now from that macro global...
It really is.
Yeah.
All the islets scattered throughout the pancreas, if you put them all together, they collectively weigh less than a single gram.
That's amazing.
And yet they are incredibly sophisticated, highly vascularized, metabolically active, and absolutely crucial to maintaining our energy homeostasis.
So who are the key players in this miniature factory team? What are the cells we need to know?
We need to remember 4 main cell types. The majority, about 70%, are the beta cells.
The beta cells.
They're the ones that produce and store insulin. Next are the alpha cells, making up about 20%, and they're responsible for synthesizing glucagon, which is insulin's antagonist.
Okay.
Then we also have delta cells, which produce somatostatin, and the F or PP cells, which produce pancreatic polypeptide. And these hormones don't just act systemically, they work together in this tight, we call it paracrine harmony within the islet to regulate each other.
Let's focus intensely on that beta cell, because its failure is, by definition, diabetes. What is the precise cascade that allows this cell to act as a sensor, linking rising blood glucose to immediate insulin secretion?
This physiological mechanism is absolutely foundational. So first, glucose enters the beta cell via specific transporters, primarily GLUT1 or GLUT2.
Okay, glucose is in the building.
Right. Once inside, the key step, the rate-limiting step, is the phosphorylation of glucose to glucose-6-phosphate. And this reaction is catalyzed by a very highly specialized enzyme.
And this enzyme is our first big physiological anchor.
Precisamente. The enzyme is glucokinase, or GK. You must remember glucokinase because it is the beta cell's physiological glucose sensor.
What makes it a sensor?
Unlike other hexokinases found elsewhere in the body, glucokinase has what's called a high QRAM, which means it has a low affinity for glucose. Its rate of activity, therefore, directly tracks the concentration of glucose available. High glucose means high GK activity.
So GK activity drives metabolism, which then generates the fuel for the next crucial step.
Exactly. The metabolism of that glucose generates adenosine triphosphate, ATP. And this ATP is the signal molecule. It acts to close a specific potassium channel embedded in the cell membrane.
The ATP-sensitive potassium channel.
Or the KATP channel, for short.
The KATP channel is so central, not just to physiology, but to pharmacology, too. We need to know its structure.
It's a complex of 8 subunits. You have 4 inward rectifying potassium channel subunits, that's KIR 6.2, and 4 sulfonylurea receptor subunits, or SUR1.
Okay.
And when ATP binds to it, it effectively closes this potassium exit channel.
So what happens when potassium can't get out?
The cell membrane depolarizes. The electrical charge changes. And this change in electrical potential then triggers the opening of voltage-gated calcium channels.
Ah, and in comes the calcium.
Calcium rushes into the cell, and that influx of calcium acts as the final trigger. It causes the insulin secretory vesicles, these tiny balloons filled with insulin, to fuse with the cell membrane and release their payload into the bloodstream. It's a really elegant, self-contained mechanism.
So that entire cascade, glucose in, ATP up, KATP closed, depolarization, calcium in, insulin out. It's beautifully efficient.
It is.
But the body has an extra layer of efficiency built in, particularly when we eat food. That's the incretin effect.
The incretin effect is a major physiological principle and, a huge target of modern pharmacology.
How does it work?
It's the observation that if you give a person, say, 50 grams of glucose orally, The resulting insulin secretion is significantly greater than if you gave them the exact same 50 grams intravenously, even if the resulting blood glucose curve is identical.
So the body senses food in the gut.
Precisely. The body knows it's coming.
And the signal for that extra boost comes from which gut peptides?
The two primary gut hormones mediating this are GLP-1, or glucagon-like peptide 1, and GIP, gastric inhibitory polypeptide. They are released from gut endocrine cells in response to food, and they potentiate the glucose-stimulated insulin secretion from the beta cells.
Which is a critical concept for understanding how drugs like the GLP-1 receptor agonists work, which I know we'll get to later.
Absolutely.
So if glucokinase is the sensor and the KATP channel is the gate controlling the electrical signal, what would happen clinically if those components were faulty? This seems like a great point for us to pause and reflect on that core concept.
That's an excellent way to consolidate the knowledge.
Right.
I mean, if there's a problem with the sensor, the glucokinase, the body just senses glucose incorrectly. If there's a problem with the gate, the KATP channel, insulin can't be released no matter what the glucose level is.
And that link is precisely what defines certain types of monogenic diabetes, where a single gene fault can just disrupt this whole cascade.
Exactly right.
Okay, so let's frame that insight for you, the learner. Here's a check-in question. What is the primary function of glucokinase in the beta cell, and what two types of subunits, specifically the functional subunits, form that crucial KATP channel?
And if you couldn't immediately recall glucokinase as the specific glucose sensor or the dual role of the KRR 6.2 and SUR1 subunits, we highly recommend you just rewind a few minutes to solidify how that beta cell mechanism works. Mastering that cascade is absolutely essential.
All right, so now that insulin is secreted, how does it actually accomplish its job of lowering blood glucose? We talk a lot about insulin resistance, but what is insulin actually facilitating in muscle and fat tissue?
Insulin is the anabolic or storage hormone. Its primary job is promoting the uptake of glucose into peripheral tissues, specifically muscle and adipose tissue, and inhibiting the breakdown of stored fuel.
And we have a great anchor for that uptake mechanism.
We do, and it's a good one to remember.
Let's hear it.
Insulin is the key that causes the door, which is the GLUT4 transporter, to move from its storage vesicles deep inside the cell cytoplasm to the actual cell membrane.
So the doors are normally kept inside?
Exactly. When insulin binds to its receptor on the cell surface, it triggers a signaling cascade that mobilizes those transporters. Once the GLUT4 doors are on the surface, they permit passive glucose entry into the muscle and fat cells.
And this mechanism is critical because type 2 diabetes is defined by those cells becoming sort of deaf to the key.
That's it. That's insulin resistance in a nutshell.
That is a perfect visualization. So insulin is the master of the fed state, facilitating synthesis and storage. What is its necessary life-saving opposition?
That role belongs to glucagon. Glucagon, produced by the alpha cells, acts primarily on the liver. Its job is to stimulate hepatic glucose production.
How does it do that?
Through two main processes. First, glycogenolysis, which is breaking down stored glycogen. And second, stimulating gluconeogenesis, which is producing new glucose from non-carbohydrate sources.
And why is glucagon so important clinically?
Glucagon is critically important for the acute defense against hypoglycemia. When your blood glucose drops, glucagon is released rapidly to mobilize those hepatic glucose stores, preventing a severe, life-threatening drop in blood sugar.
We mentioned that paracrine harmony within the islet. How does insulin keep glucagon in check locally?
So insulin, which is secreted by the neighboring beta cells, diffuses locally and acts to inhibit glucagon secretion from the alpha cells. Somatostatin from the delta cells also contributes to this local inhibition.
It's a feedback loop.
It's an essential feedback loop. When glucose is high and insulin is pouring out, the body doesn't want glucagon fighting against that effort, so it is suppressed locally.
Let's summarize the metabolic states then, using the hormone levels as the switch. The fed state first.
The fed state is defined by high insulin and suppressed counter-regulatory hormones. Metabolism shifts entirely to synthesis.
So building things up.
Exactly. Increased glucose transport via GLUT4, synthesis of glycogen in the liver and muscle, triglyceride synthesis in fat, and protein synthesis. Processes like gluconeogenesis making new glucose and lipolysis breaking down fat are largely shut down.
And the fasting state reverses this completely.
Yes, in the fasting state, low insulin levels lift the brake on catabolism, on breaking things down. This permits widespread lipolysis and the release of free fatty acids, or FFAs, into the circulation. This is necessary because many tissues, like muscle, can switch to oxidizing FFAs for energy.
And that FFA oxidation, specifically in the liver, leads to our emergency fuel source.
Correct. The liver partially oxidizes these massive quantities of FFAs, which provide substrate, like glycerol, to sustain gluconeogenesis, ensuring stable glucose for the brain. But more importantly, this rapid partial oxidation produces ketones.
Specifically acetoacetate, 3-hydroxybutyrate, and acetone.
Those are the three.
And why is the production of ketones so crucial for survival during extended energy deprivation?
Because the brain, which consumes a huge proportion of our glucose, has very little energy storage and is largely impermeable to fatty acids, so it needs an alternative fuel.
And that brings us to our third functional anchor.
Yes, ketones are the brain's emergency metabolic fuel. During prolonged fasting, or most critically, in untreated type 1 diabetes where there is absolute insulin deficiency, the body must produce ketones to sustain brain function when glucose is inaccessible or insufficient.
So when insulin is low and counter-regulatory hormones like glucagon and catecholamines are high,
Lipolysis explodes, FAs flood the liver, and ketone production becomes overwhelming, which is what leads to acidosis.
okay, understanding that complex physiology allows us to really appreciate the tests we use. Let's look at the hierarchy of glucose measurement. How do clinicians decide which test result to trust most, especially for making a definitive diagnosis?
We have to be really clear on the hierarchy. At the very bottom is urine glucose testing.
The old dipstick.
The old dipstick. It's rarely used clinically today, mainly just for historical reference or on multi-test strips. It's susceptible to cross-reactions with certain drugs, like beta-lactam antibiotics, which makes it pretty unreliable.
So we move to blood testing. Where do we get the most accurate, reliable result for a diagnosis?
For a definitive diagnosis, the gold standard remains the venous plasma glucose measurement. This is performed in a certified laboratory using automated enzymatic reactions, typically involving glucose oxidase. The strict control and calibration of that lab process offer the highest precision required to make a lifelong diagnosis.
And what about the quick finger prick measurements, the ones used for patient self-monitoring?
So capillary or arterial blood glucose, the finger prick test or point-of-care testing, serves a totally different purpose. It provides a useful, rapid approximation for monitoring acute illness, adjusting insulin doses, or for self-management.
But not for diagnosis.
Absolutely not. These readings are intrinsically less accurate than the lab venous measurement and should not be used to establish a diagnosis when the clinical stakes are so high.
Now we arrive at one of the biggest technological shifts in diabetes care in decades: continuous glucose monitoring, or CGM.
A true game changer.
This technology has fundamentally changed how patients and clinicians perceive glucose dynamics. What is the key functional definition of a CGM we should hold on to?
Our anchor here is immediate. CGM is the 24/7 glucose security camera. It has rapidly transitioned from being a niche tool to the standard of care, especially in type 1 diabetes. These sensors, placed subcutaneously, measure glucose in the interstitial fluid.
And what are the main types available to patients?
You have two main types. There's the intermittently scanned CGM, or ISCGM, often called flash monitors.
User has to scan it.
Right, they have to manually scan the sensor with a receiver or phone to get a reading. Then you have real-time CGM, or RT-CGM, which transmits data continuously to a device every 5 to 15 minutes, and that allows for immediate alarms and alerts.
And the newest ones are incredibly accurate.
They are. The latest generations often don't even require daily calibration against traditional capillary blood glucose readings anymore.
That measurement in the interstitial fluid is key. Explain the practical implication of the difference between interstitial and blood glucose, especially when levels are changing rapidly.
This is the crucial nuance for clinical decision-making. Interstitial glucose, which is what the CGM measures, has an inherent time lag, usually about 10 to 15 minutes, compared to the actual blood glucose.
So if a patient is dropping rapidly into hypoglycemia...
Exactly. Their blood glucose will already be low, but the CGM reading might still be in a safer zone because of this delay. This lag is absolutely critical to recognize during rapid changes, like after administering correction insulin or during intensive exercise.
And how do we assess the accuracy of these systems? We use the MARD metric, right?
Yes. The accuracy of a CGM is quantified by the mean absolute relative difference, or MRDAC. It's the average percentage difference between the sensor glucose reading and the reference blood glucose reading.
And lower is better.
Lower is better. Newer, advanced devices are constantly improving, achieving MARD values typically below 11%. which is essential for trusting the data for dosing decisions.
Beyond just providing numbers, what is the clinical value of having a 247 glucose profile?
Oh, the clinical value is immense. Intermittent finger prick tests provide maybe, 4 to 7 data points a day. A CGM provides hundreds. It creates a complete daily glucose profile.
So you see things you'd otherwise miss.
You identify subtle yet critical patterns that are otherwise completely invisible. Profound nocturnal hypoglycemia, post-meal glucose spikes, or extreme glucose variability. The ability to set early warning alarms for high or low events is literally life-saving, particularly for individuals with impaired awareness of hypoglycemia, or IAH, because they lose those crucial physical warning signs.
And it facilitates sharing data with the clinical team.
Exactly. It facilitates shared decision-making and, of course, forms the basis for integrating with advanced sensor-augmented insulin pump systems.
So if CGM is the real-time security camera, then glycated hemoglobin, or HbA1c, is our long-term retrospective analysis tool. What is our core anchor for this measurement?
The HbA1c is the glucose photo album. It gives us an integrated measure of blood glucose control over the entire 120-day lifespan of the red blood cell.
And how does that work?
The process is non-enzymatic. It's simply the covalent attachment of glucose molecules to hemoglobin, a process called glycation. The more glucose circulating over that 120 days, the more glycation occurs, and the higher the HbA1c value.
Now, while it covers 4 months, it's not a flat average, is it? Does it lean toward more recent glucose levels?
It does, a little. Because newer red cells are constantly being produced, the HbA1c reading is weighted slightly more heavily toward the preceding month of glucose control, but it still provides a very robust average over that longer window.
And as learners, we have to be familiar with both reporting standards.
You do. The IFCC standard, which is in mmol, and the older percentage units, or DCCT units. For context, a target of 7.0% roughly corresponds to 53 millimole.
Now we arrive at the most crucial clinical trap, the caveats. When is the photo album unreliable, giving us a potentially dangerous false reading? This concept relies entirely on understanding the red cell lifespan.
This is a very high-yield clinical concept. The measurement assumes a normal 120-day red cell lifespan. Therefore, any condition that changes that lifespan will distort the HbA1c result relative to the patient's true average glucose.
Okay, let's spell that out. When would we see an erroneously low HbA1c?
A falsely low reading occurs when the red cell lifespan is shortened. For example, if a patient has chronic blood loss, sickle cell disease, thalassemia, or is pregnant, their red cells are being destroyed or turned over faster than normal.
Less time for glycation.
Exactly. Less time means a lower HbA1c, even if the patient's average glucose is actually quite high. Similarly, a recent large blood transfusion introduces new non-glycated hemoglobin, also artificially lowering the result.
And conversely, how could we see an erroneously high HbA1c?
A falsely high reading results if the red cell lifespan is extended. This occurs notably in specific types of anemia iron deficiency anemia, or B12 folate deficiency anemia. The red cell lives longer, allowing more time for that non-enzymatic glycation to accumulate, resulting in an artificially high reading.
So a splenectomy would do the same?
It would. Patients who have undergone a splenectomy often have longer red cell survival, leading to a higher result. You must always interpret the HbA1c in the context of the patient's full blood count and clinical state.
That explanation of the mechanism makes the caveat stick so much better. Let's integrate this detail for you, the listener. Here's your check-in question. If you suspect a patient has chronic, untreated iron deficiency anemia, how would you expect their HbA1c measurement to deviate from our actual average blood glucose, and why?
If you didn't connect the extended red cell lifespan with a falsely high reading due to increased time for glycation, please review those red cell lifespan factors now. It's a common exam question for a reason.
Okay, let's move to the 3 specialized diagnostic tools, starting with ketones, which are vital for acute management.
Blood ketones are now the preferred clinical measure. While urine tests still exist, they detect acetoacetate via the nitroprusside reaction blood testing for beta-OHB or beta-hydroxybutyrate. The major ketone in acidosis is just faster and more reliable.
And this is essential for sick day management in type 1.
It is. And crucially, a reading above 3.0 millimole is the threshold for mandatory urgent medical consultation. It signals the likely onset of diabetic ketoacidosis, or DKA.
Next, the immunological confirmation. Islet autoantibodies. When are these necessary?
We use these to confirm the immune-mediated destruction of type 1 diabetes, a process called insulitis. The core panel includes anti-insulin, anti-GAD, anti-IA2, and anti-ZNT8. The The presence of these antibodies suggests an autoimmune process is underway.
And the clinical sensitivity increases if you test for more than one.
It does, greatly. Anti-GAD and anti-IA2 together cover roughly 85% of new type 1 cases, including anti-ZDA8 can push that sensitivity well over 90%. And the presence of high-titer antibodies, or multiple antibodies, significantly increases the probability of progression to absolute insulin deficiency.
And finally, C-peptide, the marker of endogenous insulin. Why is this so crucial in a world where almost all type 1 patients are injecting insulin?
C-peptide is secreted in equimolar amounts with endogenous insulin from the beta cells. Critically, synthetic insulin does not contain C-peptide.
So it's a pure marker of what the body is making itself.
It's the perfect metric for measuring residual beta cell function, even when a patient is receiving high doses of external insulin. A serum C-peptide level below 200 pMOA is highly suggestive of severe endogenous insulin deficiency, characteristic of type 1 diabetes.
And what's the key procedural requirement for this test?
You must always measure C-peptide simultaneously with a blood glucose level above 4.0 millimole. If the patient is hypoglycemic, their beta cells are naturally suppressed, which would give you a misleadingly low C-peptide result.
We mentioned screening for long-term complications earlier. Let's drill down on the essential annual test for kidney disease, microalbuminuria.
This annual screen for diabetic kidney disease, or DKD, is mandated for all adults with diabetes. The goal is early detection of albumin excretion that is too low to be picked up by a standard urine dipstick.
Which only flags bigger amounts.
Exactly. Microalbuminuria is defined by an albumin to creatinine ratio, or ACR, within the range of 2.5 to 30 millimole in men and 3.5 to 30 in women.
And why is one sample not enough for diagnosis?
Because albumin excretion can be transiently increased by things like exercise, fever, or a UTI. To confirm true microalbuminuria, we require 2 out of 3 first morning samples to fall within that specific range. Persistent microalbuminuria is a strong predictor of progressive kidney damage and requires targeted medical intervention.
Okay, let's wrap up diagnostics by clarifying the high-risk states that precede overt diabetes, the pre-diabetes category.
Prediabetes defines states of increased risk that have not yet met the criteria for diabetes diagnosis. We identify 2 distinct metabolic patterns, usually via the oral glucose tolerance test, or OGTT, where the patient ingests 75 grams of glucose.
What defines impaired glucose tolerance, or IGT?
IGT is defined by a normal fasting glucose, but an elevated 2-hour glucose reading following the OGTT. Clinically, IGT is particularly linked to an increased risk of macrovascular disease, myocardial infarction, and stroke even before overt diabetes is diagnosed.
And impaired fasting glucose, IFG.
IFG is the reverse.
Yeah.
Elevated fasting glucose, but the 2-hour post-load glucose is normal. IFG is more strongly linked to the progression toward overt diabetes. In both cases, the underlying pathology is usually insulin resistance that the pancreas is struggling to overcome.
So what's the consensus advice for patients diagnosed with either IG2 or IFG?
The primary advice is intense lifestyle modification, diet, and exercise, which can often delay or even prevent the onset of overt type 2 diabetes. Furthermore, we must aggressively screen and manage the associated cardiovascular risk factors that are already present, things like hypertension and dyslipidemia, because that macrovascular damage often begins in the pre-diabetes phase.
Understanding the etiology is crucial for choosing the right treatment. Let's start Section 3 by returning to type 1 diabetes and the pathology of immune-mediated destruction.
Type 1 is fundamentally an autoimmune condition. It involves the inflammatory infiltration, we call it insulitis, of pancreatic islets by T lymphocytes, leading to the progressive and irreversible destruction of the beta cells.
And this process happens over years, right? It's not sudden.
Correct. It occurs over years, with autoantibodies present long before the patient becomes symptomatic, leading eventually to absolute insulin deficiency.
What are the key genetic markers we must remember that predispose individuals to this autoimmune attack?
So, type 1 diabetes is polygenic, meaning multiple genes contribute to risk. There are over 20 risk loci. However, the strongest association by far lies within the human leukocyte antigen, or HLA, region on chromosome 6.
Specifically, which haplotypes?
Specifically, the HLA-DR3 and HLA-DR4 haplotypes confer the highest susceptibility.
And why is the HLA region so important in an autoimmune disease?
The HLA genes encode proteins responsible for antigen presentation to T lymphocytes. Certain variants of these genes seem to present beta cell antigens more effectively or inappropriately to the immune system, initiating that T-cell-mediated attack against the body's own insulin-producing cells.
Let's discuss the environmental triggers again, because this is where a lot of ongoing research sits. What are the hypotheses regarding factors that might precipitate the autoimmune response in a genetically susceptible person?
Environmental factors are believed to provide the spark for the genetic tinderbox. The triggers are still poorly defined, but they fall into several categories. Viruses, such as Coxsackie-B4, mumps, and rubella, are strong candidates, perhaps through a mechanism called molecular mimicry.
Where the virus looks like a beta cell protein.
Exactly. We also look at chemical toxins, like certain nitrosamines or even coffee compounds.
And the fascinating, if controversial, link to bovine serum albumin, or BSA. Can you elaborate on that hypothesis?
Yes, this is a classic example of an environmental hypothesis. Here's where it gets really interesting. The idea is that bovine serum albumin, a major protein in cow's milk, may cross an infant's gut wall, especially if introduced early, and generate an immune response.
And that immune response goes rogue.
Potentially. The resulting antibodies might then cross-react with a heat shock protein expressed on human beta cells. This is part of the broader reason why early diet and the composition of the gut microbiome are such intensely studied areas in type 1 pathogenesis.
And the hygiene hypothesis also fits this picture of altered early immune exposure.
Absolutely. The hygiene hypothesis suggests that reduced exposure to microbes and infections in early childhood leads to a less educated or improperly trained immune system, thereby increasing susceptibility to autoimmunity in general. We also link vitamin D deficiency to type 1 incidence, given the higher rates observed in less sunny polar regions.
Clinically, the onset of type 1 is often dramatic, but there's a cruel twist once the acute symptoms are treated: the honeymoon period.
Patients usually present with an acute history of those osmotic symptoms and weight loss, often culminating in DKA. But following treatment, after the initial hyperglycemia is corrected, patients often experience the honeymoon period. This is a partial, temporary recovery of their beta cell function.
Why does this temporary recovery happen?
It's because the initial severe hyperglycemia caused damage to the remaining beta cells, a process we call glucotoxicity. Once you correct the glucose with insulin, you reverse this toxicity, and the remaining healthy beta cells briefly come back online, producing significant amounts of endogenous insulin.
So their insulin needs drop dramatically.
They do. During this period, the patient's need for exogenous insulin drops, and their control is often smooth and easy.
Which gives the patient false hope, of course.
Sadly, yes, because the underlying relentless immune-mediated destruction process continues, and it eventually destroys those few remaining beta cells, leading to an absolute permanent requirement for exogenous insulin therapy.
Okay, let's pivot to type 2 diabetes, where type 1 is absolute destruction, type 2 is a failure to compensate for resistance. What is the fundamental pathogenic duo we must anchor on?
The anchor for type 2 is the pathogenic duo: insulin resistance combined with beta cell failure. Insulin resistance in peripheral tissues, strongly linked to obesity, develops first. Initially, the beta cells work overtime to compensate, but eventually they fail to produce enough insulin to overcome this resistance.
I like the visualization of the progressive race condition. Can you walk us through that sequence of failure?
Imagine it as a race. The first phase is characterized by rising insulin resistance. The beta cells successfully compensate by secreting vastly increased amounts of insulin. Glucose remains normal glycemia.
So for a long time, everything looks fine on the surface.
Exactly. But the beta cells cannot maintain this hypersecretion indefinitely. Over years, their functional capacity declines due to exhaustion and toxicity. When the required insulin secretion, let's call it the gray line, drops below the level needed to overcome the resistance, the green line, that's when glucose levels start to rise and overt diabetes is diagnosed.
What are the primary factors that drive that initial peripheral insulin resistance?
The central cause is obesity, particularly visceral, intra-abdominal, or central adipose tissue. This fat is highly metabolically active. It releases huge quantities of free fatty acids and inflammatory adipokines.
And these FFAs are the problem.
They are. These circulating FFAs interfere with insulin signaling in muscle and liver, inducing resistance. Reduced physical activity makes this worse by downregulating insulin-sensitive kinases.
We must also remember the genetic component here, even though the environment dominates.
Absolutely. While type 2 is often seen as a lifestyle disease, genetics sets the stage. The largest known genetic risk factor in the population is a variation in the TCF7L2 transcription factor.
What's the effect size of that?
Those carrying 2 copies of this variant almost double their lifetime risk of developing type 2 diabetes. It demonstrates that even in this complex polygenic disease, certain genetic elements wield significant power.
We mentioned glucotoxicity in type 1. Does toxicity play a role in type 2 beta cell failure as well?
Yes, toxicity is a massive contributor to the progression of beta cell failure in type 2. It's a double whammy. Glucotoxicity, where high plasma glucose actively damages the beta cells, and lipotoxicity, where high circulating FFAs also damage the beta cells.
And this reduces their ability to secrete insulin.
Correct. But the good news is that these toxic effects are often partially reversible if we manage to achieve tight glucose control early in the disease course.
Type 2 is rarely an isolated finding. It's tightly associated with the broader metabolic syndrome. What is the clinical picture we should look for?
The metabolic syndrome is a cluster that includes hypertension, characteristic dyslipidemia, high triglycerides, and low HDL cholesterol and non-alcoholic fatty liver disease, or NAFLD.
And in women.
In women, it is also highly linked to polycystic ovarian syndrome, or PCOS. Clinically, severe insulin resistance often manifests externally as acanthosis nigricans.
We mentioned that before, the dark skin patches.
Right, that characteristic velvety dark pigmentation seen most commonly on the neck, in the axillae, and in other skin folds. It is a visible sign of profound hyperinsulinemia trying to overcome resistance.
Let's touch on that key subtype that bridges type 1 and type 2. Ketosis-prone type 2 diabetes or flatbush syndrome.
This is a high-yield clinical concept.
Oh.
It occurs in type 2 patients, often of African American, South Asian, or Hispanic descent, who suffer a severe acute stress, like a major infection.
And that stress pushes them over the edge.
It tips them into such profound relative insulin deficiency that they present with DKA, making them look clinically identical to a new-onset type 1 diabetic.
But the pathology is different.
Yes. They initially require insulin to resolve the DKA, but as the acute illness subsides and the glucotoxicity and lipotoxicity reverse, their underlying beta cell function often recovers. These patients can frequently be transitioned back off insulin entirely and managed successfully with oral agents like metformin within a few months.
Which distinguishes them fundamentally from type 1 patients who have absolute permanent destruction.
Exactly.
Finally, let's explore monogenic diabetes, where understanding a single gene mutation can instantly change the entire treatment plan. This is a powerful demonstration of personalized medicine.
Monogenic diabetes encompasses several rare forms, typically inherited in an autosomal dominant fashion. MODY, or maturity onset diabetes of the young, is the most common form. It's defined by onset typically before 25 years of age and no initial requirement for insulin.
Which MOY is the most crucial one for us to anchor on as learners?
Glucokinase MODY, GK-MODY, is absolutely essential. Remember our earlier anchor. Glucokinase is the beta cell sensor. A mutation here effectively raises the glucose set point for the entire body. It's like having a faulty thermostat.
What are the clinical consequences of that faulty sensor?
The patient has mild, stable hyperglycemia throughout their life. But crucially, because the damage is mild and stable, they typically do not develop the long-term microvascular complications seen in other diabetes types.
So what's the takeaway?
The vital takeaway here is that these patients usually do not require any glucose-lowering drugs or monitoring. If you diagnose GK-MODY, you save the patient years of unnecessary insulin, testing, and stress.
That makes the diagnosis incredibly high yield. What about the transcription factor MODYs like HNF1 alpha and HNF4 alpha?
These cause a more progressive form of diabetes. However, genetically diagnosing these types is also revolutionary because they respond extremely well to sulfonylurea drugs.
Why is that?
Sulfonylurias work by stimulating insulin release via directly closing the KATP channel, effectively bypassing the transcription factor issue. Genetic confirmation allows these patients to potentially switch off long-term insulin therapy and manage the condition with a simple tablet.
And the connection to the KATP channel is even more dramatic and life-changing in neonatal diabetes.
Neonatal diabetes presents in the first 6 months of life a very different clinical picture. 2/3 of permanent cases involve an activating mutation in the KATP channel subunits, either KIR6.2 or SUR1. This mutation makes the channel permanently open.
So the ATP signal can't close it.
Exactly, which shuts down insulin secretion entirely.
And the life-changing treatment implication.
Because the channel is permanently open, the treatment is to overwhelm that channel with a high-dose sulfonylurea. These patients, diagnosed in infancy and placed on insulin, can often be switched to high-dose sulfonylureas, allowing them to discontinue insulin therapy completely.
That's incredible.
It is. And furthermore, because the KATP channel is also found in the nervous system, switching them to sulfonylureas can sometimes improve their neurological outcomes as well, transforming their prognosis entirely. This is the pinnacle of how understanding pathogenesis leads to precision medicine.
That is a phenomenal transition from the generalities of type 1 and type 2 to the specifics of genetic precision. Let's integrate what we've just learned. Another check-in question for you. Which specific type of monogenic diabetes is characterized by mild, stable hyperglycemia, where the patient almost never requires glucose-lowering drugs because the fundamental problem is simply a raised physiological set point?
If you didn't recall glucokinase MODY, we strongly advise revisiting the beta cell sensor system back in section 1.2.
We've established the long-term pathology. Now we must focus on the two life-threatening acute emergencies, severe hyperglycemia and hypoglycemia. Starting with hyperglycemia, what are the classic osmotic symptoms that should immediately raise suspicion?
The classic triad of osmotic symptoms is polyuria, which is frequent urination, nocturia, waking up to urinate, and polydipsia, excessive thirst.
And where do these come from?
They arise because when blood glucose exceeds the renal threshold, which is around 10 millimole, the glucose spills into the urine. It acts as an osmotic agent, pulling huge volumes of water with it. This leads to osmotic diuresis and subsequent profound dehydration.
And patients also report other things.
Yes, they frequently report tiredness, blurred vision, which is due to osmotic swelling of the lens, and recurrent mucosal candidiasis.
If a patient presents with new onset hyperglycemia, the most critical step for initial triage is determining the underlying metabolic state. How do we rapidly assess the urgency?
You must immediately test for ketones in the urine or the blood. The presence of raised ketones, a blood ketone level above 3.0 millimole, is a red flag.
Well, what does that mean?
That finding implies absolute or severe relative insulin deficiency and demands urgent specialist intervention. That result usually signals type 1 diabetes or a severe decompensated type 2 patient on the verge of DKA.
Okay, let's dive into DK. This is a medical emergency, most common in type 1, but possible in that ketosis-prone type 2 group. What are the common scenarios that precipitate DKA in an established type 1 patient?
The most common scenarios are an acute concurrent illness, such as a major infection like pneumonia or a UTI, or an acute cardiac event like an MI or a stroke, or a physiological stress like surgery or trauma.
But often it's simpler than that.
Often, yes. The cause in established type 1 diabetes is simply insulin deficiency, missing doses, pump failure, or errors in calculation. The absence of insulin is the core engine driving the crisis.
How should we anchor the pathogenesis of DKA for maximum memory retention?
Our core anchor for DKA is this. DKA is a car running on emergency fuel with a toxic exhaust. The car is running on fat through lipolysis, and the toxic exhaust is the acid produced, the ketones.
And we define DKA by a biochemical triad.
Correct. 1, hyperglycemia, usually over 11 millimole. 2, severe acidosis, a pH less than 7.3 and bicarbonate less than 15 millimole. And 3, significant ketosis, so blood ketones over 3.0 millimole.
Can you elaborate on the mechanism of the acidosis?
With absolute insulin deficiency, the body experiences unrestrained lipolysis, flooding the circulation with free fatty acids. These FFAs are taken up by the liver and rapidly converted into the acidic ketones acetoacetate and beta-hydroxybutyrate.
And the body can't keep up.
The rate of ketone production completely overwhelms the body's ability to clear or metabolize them, resulting in a severe high-anion gap metabolic acidosis. The patient is essentially auto-acidifying themselves.
What are the telltale clinical signs that allow us to spot DKA immediately at the bedside?
You look for signs of profound volume depletion and dehydration, dry mucous membranes, reduced skin turgor, tachycardia, and hypotension. And because of the severe acidosis, the patient will exhibit a specific respiratory pattern called Kussmaul breathing.
What does that look like?
It's deep, sighing, regular hyperventilation. This is the body's attempt to blow off CO2 rapidly to compensate for the metabolic acid load. Additionally, the patient's breath may have a distinctive sweet, pear-like odor, the smell of acetone, one of the 3 ketones.
That contrasts strongly with the other acute crisis, HHS, or hyperglycemic hyperosmolar state. Where does HHS sit in the clinical spectrum, and in whom does it typically occur?
HHS is usually a condition of the elderly type 2 patient, often presenting after an acute illness or infection that has progressed over days or even weeks. The defining clinical features are profound hyperglycemia and extreme dehydration.
And the fluid losses are shocking.
They are, often reaching 10 to 22 liters, which is far greater than the deficit typically seen in DKA.
The major differentiating factor is the absence of significant ketoacidosis. Why does HHS not lead to DKA despite astronomical glucose levels?
The fundamental difference is the level of insulin. In HHS, the patient has just enough residual endogenous insulin, often barely measurable, but it's present, to suppress that massive runaway lipolysis and hepatic ketogenesis.
So the car is not running on emergency fuel.
Exactly. So while insulin levels are too low to allow glucose uptake, causing extreme hyperglycemia, they are high enough to stop the ketone production. The diagnostic criteria are profound hyperglycemia, but virtually no ketosis, with blood ketones typically less than or equal to 0.6 millimole and only mild or absent acidosis.
Given that the fluid deficit can be up to 22 liters, fluid replacement must be the immediate clinical priority.
It absolutely is the priority. Management is intensely focused on rehydration, usually with 0.9% saline. However, because the hyperosmolality can be so profound, fluid replacement must be slower and more cautious than in DKA to avoid rapid shifts in brain osmolality, which can lead to cerebral edema.
So insulin is secondary.
Insulin infusion is required to lower the glucose, but correcting the fluid status and osmolality is the immediate life-saving step. And because HHS patients are often elderly and profoundly dehydrated, leading to a procoagulant state, aggressive thromboprophylaxis is also essential.
Let's swing to the opposite end of the spectrum. Hypoglycemia, the most common acute complication of insulin therapy. What is the clinical definition?
Hypoglycemia is defined as the presence of symptoms combined with a low plasma glucose level, typically below 4.0 millimole, which is around 72 milli-GDL.
And we categorize it by severity.
We do. Level 3 is severe hypoglycemia, meaning the patient is unconscious, comatose, or otherwise requires external help from medical staff or family for recovery.
What causes this dangerous dip in blood sugar?
Hypoglycemia results from a perfect storm of factors where the insulin dose or activity outweighs the carbohydrate intake and endogenous glucose production. Common causes include excess insulin, a missed or delayed meal, recent intense exercise.
Why exercise?
It increases non-insulin-dependent glucose uptake by muscle. Also renal or liver disease, which reduces insulin clearance and gluconeogenesis, respectively, or alcohol consumption, which suppresses hepatic gluconeogenesis.
When patients feel the onset of a hypo, their symptoms usually fall into two classic groups.
Yes, the symptoms reflect the two systems reacting. First, the autonomic symptoms, mediated by the acute sympathetic nervous system response. Sweating, trembling, rapid heart rate or palpitations, intense hunger, and anxiety. These are the body's warning signs.
And the second group?
The neuroglycopenic symptoms, which are due to brain glucose deprivation, delirium, confusion, drowsiness, difficulty speaking, and extreme irritability. Importantly, symptoms are highly variable between individuals and even within the same individual over time.
And this leads us to the silent, terrifying threat, impaired awareness of hypoglycemia, or IAH. Why is this so dangerous?
IAH occurs when a person frequently experiences hypoglycemia. Their body adapts by shifting the glucose threshold required to trigger those autonomic warning symptoms lower and lower. They might not feel the sweating or trembling until their glucose is already dangerously low, significantly increasing their risk of a severe level 3 event.
And their counter-regulatory system is also failing them, correct?
Absolutely. Compounding IAH, many people with type 1 diabetes lose their protective glucagon response, often within 5 years of diagnosis. They become entirely reliant on secondary hormones like adrenaline and cortisol, making them extremely vulnerable to severe, prolonged hypoglycemia.
Let's detail the treatment protocol for conscious and unconscious patients.
For level 1 or 2 hypoglycemia, the conscious patient, the immediate treatment is 15 to 20 grams of fast-acting carbohydrate, orally like glucose tablets or sugary juice. Once the glucose is confirmed to be above 4.0 millimole, they should follow this up with a long-acting carbohydrate snack to prevent a relapse.
And for the unconscious patient?
For level 3, unconscious or unable to swallow, treatment is immediate. Glucagon 1 milligram via intramuscular injection or IV 10% glucose infusion. And a critical rule for management is to never administer a scheduled insulin dose until the patient is conscious and their blood glucose is safely corrected.
That distinction between DKA and HHS is clinically critical and often tested. Before we proceed, let's ensure that distinction is anchored. Check-in question time. Which acute complication, DKA or HHS, is classically associated with the deep, sighing, Kussmaul breathing pattern, and what is the underlying physiological reason for this specific breathing effort?
If you couldn't link Kussmaul's hyperventilation directly to DKA's severe metabolic acidosis, please rewind and review the DKA section immediately. It's a life-saving distinction to know cold.
Okay, diabetes is a systemic vasculopathy that affects nearly every organ. So the physical examination is more than just a formality. It's a critical tool for detecting complications early. What are the key observations we should prioritize in a head-to-toe check?
We start with general observation. You note the body habitus weight loss, which you might see in type 1, or obesity in type 2. You check for signs of dehydration, oral candidiasis, and if they're acutely ill, you note Kussmaul breathing. We must systematically examine the high-risk areas.
Let's go through some specific areas, starting with the skin and joints, as they reveal long-term glycation effects.
You look at the skin, especially where insulin resistance is suspected. We've mentioned acanthosis nigricans, the dark, velvety pigmentation on the neck and axillae. You also look for necrobiosis lipoidica, which presents as these scarred yellow plaques with a violaceous border, typically on the shins.
And the connective tissue complications are often missed. What is the key test for limited joint mobility?
The key anchor is the prayer sign. This simple test checks for limited joint mobility, or chiroatropathy. The patient attempts to put their palms together, and if they cannot fully extend the metacarpophalangeal or interphalangeal joints bilaterally, it indicates a problem.
And what's causing that?
It's due to the non-enzymatic glycation of collagen over time, leading to thickened skin and tendons. This also contributes to Dupuytren's contracture, carpal tunnel syndrome, and trigger finger.
We must also inspect insulin injection sites diligently, particularly in patients struggling with variability. What are we looking for there?
You are inspecting for bruising, erythema, and the most common problem, lipohypertrophy. This is a localized deposition of subcutaneous fat caused by the local trophic action of insulin from injecting into the same area repeatedly.
And the clinical consequence of that is huge.
It is. Injecting into lipohypertrophy causes dramatically impaired and highly unpredictable insulin absorption, leading to wildly variable blood glucose control. Patient education on meticulous site rotation is absolutely non-negotiable.
Let's transition to the microvascular complications, the big three, caused by years of elevated glucose-damaging small blood vessels. What is the fundamental mechanism of this microangiopathy?
The long-term exposure to high glucose activates multiple biochemical pathways, like the polyol pathway and the formation of advanced glycation end products, or AGs, all culminating in excessive oxidative stress and inflammation.
And what's the physical hallmark?
The physical hallmark of diabetic microangiopathy is the progressive thickening of the capillary basement membrane and increased vascular permeability throughout the body.
This mechanism hits the eyes, kidneys, and nerves hardest. Let's start with the kidney diabetic kidney disease, or DKD.
DKD is now the single most common cause of end-stage renal disease globally. The classic progression starts with glomerular hyperfiltration. The kidney initially works too hard, followed by the onset of microalbuminuria, progressing to frank proteinuria, and eventually terminal renal failure.
And pathologically, what's the definitive feature on biopsy?
The definitive pathognomonic feature seen on a kidney biopsy is the Kimmel-Steele-Wilson nodule, a nodular glomerulosclerosis. Early aggressive control of blood glucose and blood pressure is the only way to slow this devastating progression.
And nerve damage, or diabetic neuropathy. This is often described as the silent threat because it can remove the protective function of pain.
The most common form is symmetrical sensory polyneuropathy, affecting nerves in a glove and stocking distribution. It hits the longest nerves first, so it starts in the feet. Early symptoms can be excruciating, described as sharp pain, burning, or electrical shocks, often worse at night. But critically, it leads to the loss of protective sensation.
How do we test for that loss of protective sensation?
We use the 10-gram monofilament test. If the patient cannot reliably feel the pressure of this monofilament on specific points of the foot, they have lost protective sensation. This single finding is the key clinical predictor of risk for foot ulcers.
Because they can't feel the injury.
Exactly. Without the ability to feel pain or pressure, minor trauma or continuous pressure points become major non-healing foot ulcers.
And what about the less common but highly significant autonomic neuropathy?
This affects the nerves that control involuntary functions. It can cause postural hypotension, reducing the patient's tolerance for standing upright. It can cause resting tachycardia. And most disablingly, it can cause gastroparesis, delayed gastric emptying.
Which causes huge problems with eating and glucose control.
It does. It results in unpredictable nausea, vomiting of undigested food, and chaotic blood glucose control because the timing of food absorption is completely mismatched with their insulin delivery. Overt autonomic neuropathy is associated with an extremely poor prognosis, with mortality rates of 50–70% within 10 years of diagnosis.
Let's focus specifically on diabetic foot disease. This combination of neurological and vascular damage is the most common reason for prolonged diabetes-related hospitalization and the leading cause of non-traumatic lower extremity amputation. What is the triple threat here?
The foot is under constant attack from the triple threat. 1. loss of protective sensation from neuropathy. 2, inadequate blood supply from peripheral vascular disease or ischemia. And 3, infection.
So ulceration starts small.
It starts small, often initiated by minor, unnoticed trauma, especially under areas of callus formation at pressure points, which the patient can't feel.
How do clinicians organize the annual screening and risk assessment? We use a clear traffic light system.
The annual screening mandates checking the 10-gram monofilament for sensation and palpating the foot pulses. The results categorize the patient's risk.
What's green?
Green is low risk. It means normal sensation and pulse is present. Self-care education is sufficient. Amber is moderate risk. This means they have lost sensation or they have absent pulses. This requires immediate referral for specialist podiatry assessment.
Yeah,
Red is high risk. This means they have lost sensation and have absent pulses, or they have a foot deformity or significant callus. This requires ongoing specialist team care and prescription orthotic footwear.
And when do they need urgent, acute care?
Any patient presenting with an active foot ulcer, signs of infection like pus or redness, or the telltale presentation of Charcot neuroarthropathy. A hot, red, swollen, but often painless foot requires immediate, urgent, multidisciplinary team referral and hospitalization.
Tell us more about Charcot neuroarthropathy.
Charcot, though rare, is devastating. It is a severe complication of neuropathy causing acute bone destruction, joint dislocation, and pathological fractures. The crucial management step is immediate, prolonged pressure relief and immobilization, often using a total contact plaster cast or a specialized air cast boot for months on end to prevent progressive and debilitating foot deformity. You must recognize it quickly, as a patient with an acute Charcot foot often mimics cellulitis, but standard antibiotics won't help. We've established the massive clinical scope of diabetes. Now let's focus on modern management. What are the two core, often conflicting goals for long-term therapy?
The goals are, 1, to relieve osmotic symptoms and prevent acute crises, and 2, to minimize long-term microvascular complications, which we do via strict glucose control, and macrovascular complications, which we do via aggressive cardiovascular risk factor control.
What is the usual long-term glycemic target, the HbA1c, that we aim for in the majority of patients?
The standard target is 53 millar-Laramal, which is approximately 7.0%, and this target is applied to both type 1 and type 2 patients. However, and this is a huge target, however, we must strongly emphasize the principle of individualization of care.
Okay, so when do we aim for tighter control, below 7.0%?
We aim for lower targets, perhaps 48 millimole, around 6.5%, in newly diagnosed type 2 patients who are low risk for hypoglycemia and have a long life expectancy to maximize their microvascular benefit. We also aim lower in type 1 patients using advanced technology like sensor-augmented pumps, because the technology substantially mitigates the risk of severe hypoglycemia. And when do we allow for a much higher, more relaxed target?
We set higher, looser targets, perhaps 58 millimole or greater in older patients, those with multiple severe comorbidities, a short life expectancy, or most importantly, in patients who have a high risk of level 3 hypoglycemia.
Especially if they have impaired awareness of hypoglycemia.
Exactly, or cognitive impairment. For these patients, preventing a life-threatening hypolid takes precedence over achieving a tight A1C.
And we also have to address the macrovascular risk factors.
We do. This means targeting hypertension. Blood pressure should be kept below actually 40/80 millar-fetal Hg generally, or even tighter, below 130/80 if the patient has established renal disease. Furthermore, statin therapy is automatically recommended for virtually all type 2 patients over the age of 40, irrespective of their baseline cholesterol level.
Let's discuss the core therapeutic agents for type 2 diabetes. Metformin is the undisputed first-line treatment. How does this big 1A drug primarily work?
Metformin is the foundation. Its primary mechanism is reducing hepatic glucose production. It suppresses gluconeogenesis in the liver, meaning the liver releases less glucose into the blood. So its main impact is on fasting glucose levels.
And what are the risks and contraindications?
Common side effects include GI upset, like diarrhea, which is often managed by starting with a low dose and escalating slowly. The rare but deadly risk is lactic acidosis. Consequently, metformin is absolutely contraindicated if the eGFR is below 30 mmol/min, 1.73 metasnor, and the dose must be reduced significantly if the eGFR falls below 45.
Next, sulfonylureas, or SUs. They work directly on the physiology we discussed earlier, right?
Exactly. Sulfonylureas are secretagogues. They stimulate the beta cell to secrete insulin by binding directly to the SUR1 subunit of the KATP channel, forcing it shut and triggering insulin release. And crucially, this effect is largely independent of the ambient glucose concentration.
Which means a high risk of hypos.
It does. This potent mechanism means they carry a high risk of hypoglycemia and usually cause weight gain, which is why they're often avoided in patients with jobs where hypoglycemia could be catastrophic.
Pioglitazone, ethizolidinedione, or TZD. How does the sensitizer differ from metformin?
Pioglitazone is a powerful insulin sensitizer. It works by activating a nuclear receptor called PPAR-gamma, primarily in adipose tissue. This activation enhances the action of endogenous insulin in peripheral tissues, helping muscle and fat respond better to the insulin that is produced.
But there are side effects.
Yes, its side effects include weight gain and fluid retention, which must be considered in patients with pre-existing heart failure.
Moving to the incretin-based therapies. First, DP4 inhibitors.
DPP-4 inhibitors, or the gliptins, are orally administered and prevent the rapid breakdown of the naturally occurring gut hormones GLP-1 and GIP. By extending the half-life of these natural incretins, they enhance glucose-dependent insulin release.
And because it's glucose-dependent?
They have a low intrinsic risk of causing hypoglycemia.
And their injectable or oral cousins, the GLP-1 receptor agonists, are much more potent.
GLP-1RAs are transformative. They're administered usually via injection, though oral formulations now exist. They mimic the natural GLP-1 hormone, but are resistant to DPP-4 breakdown. They achieve powerful glucose lowering, delay gastric emptying, and act centrally on the hypothalamus to suppress appetite.
Leading to significant weight loss.
Exactly. Clinically significant weight loss, typically 3 to 5 kilograms or more.
And beyond glucose and weight, what is their crucial systemic benefit?
They have demonstrated proven, robust cardiovascular benefit in patients with established cardiovascular disease, with agents like liraglutide and semaglutide reducing the risk of major adverse cardiac events. The main side effects are GI nausea and vomiting, which are managed by a slow, careful up-titration of the dose.
Finally, the revolutionary class, SGLT2 inhibitors. These drugs are the most exciting development in decades because of their triple threat benefit.
SGLT2 inhibitors are a management anchor. They are the 3-in-1 drug. They target the kidney, specifically blocking the sodium-glucose cotransporter 2 in the proximal renal tubule. This effectively lowers the renal threshold for glucose, causing controlled glycosuria or glucose loss in the urine.
And what are the three major benefits that flow from this mechanism?
1. Glucose lowering via glucose excretion. 2. Significant weight loss because patients excrete 200 to 300 kilocal of glucose per day. And 3. Blood pressure reduction due to natriuresis or sodium loss accompanying the glucose.
And the long-term paradigm-shifting benefits in heart and kidney disease.
This is the crucial takeaway. SGLT2 inhibitors have demonstrated compelling cardiac protection, particularly in heart failure, and proven renal protection, dramatically reducing the progression to end-stage kidney disease by about 30% in patients with proteinuria, independent of their glucose-lowering effect. The mechanism seems linked to a beneficial shift in renal hemodynamics and natriuresis.
What are the two primary risks associated with this drug class?
The main adverse effect is genitourinary infections, specifically genital mycotic or fungal infections like vaginal thrush or balanitis, simply because there is now sugar present in the urine. The rare but serious risk is euglycemic DKA that occurs without marked hyperglycemia. This is typically precipitated by acute illness or dehydration and requires strict sick day rules where patients must stop the medication when acutely ill.
That dual benefit for the heart and kidney makes SGLT2 inhibitors arguably the most important drug discovery since insulin. Let's pause here to confirm this management strategy is clear. Another check-in question for you. Which relatively new class of glucose-lowering agents provides simultaneous cardiovascular and renal protection, causes weight loss, but carries a specific common risk of genital fungal infections due to its mechanism of action?
If you didn't immediately name SGLT2 inhibitors, please review this critical class in the last section.
For type 1 diabetes, and for many type 2 patients requiring intensive control, insulin therapy is essential. Modern practice relies heavily on insulin analogs. How do these analogs improve on older human insulin?
Insulin analogs have been structurally modified to optimize their pharmacokinetic profiles. This gives us tight control over onset and duration. For example, rapid-acting analogs like insulin lispro and aspart are absorbed faster, allowing patients to inject them immediately before a meal.
And the long-acting ones?
Conversely, long-acting analogs like glargine and degludec are engineered for prolonged peakless action, providing a steady basal rate for 24 or even 48 hours, which significantly reduces nocturnal hypoglycemia risk compared to older, long-acting insulins.
For patients on basal bolus regimens, calculating the meal dose precisely is a learned skill. What are the two essential personalized factors required for this calculation?
The total bolus dose for a meal is based on two individualized factors determined through titration. First, the insulin to carbohydrate ratio, for example. 1 unit of rapid-acting insulin might be required to cover 10 grams of carbohydrate.
And the second?
The second is the insulin sensitivity factor, or correction factor. For example, 1 unit of insulin lowers the blood glucose by 3 millijans. The patient has to calculate the carbohydrate dose and add any correction dose needed to bring a prevailing high glucose back to target.
The highest level of control is achieved via continuous subcutaneous insulin infusion, or CSII, the insulin pump. What is the key advantage of a pump over multiple daily injections?
The primary advantage is precision and flexibility. The pump delivers only rapid-acting insulin continuously via a highly variable basal rate, which can be adjusted minute to minute or hour to hour. This allows for far better fine-tuning of control, especially overnight, and drastically reduces glucose variability. It also helps patients avoid insulin stacking, where overlapping doses lead to dangerous, unpredictable hypoglycemia.
But the pump introduces a severe rapid risk that MDI users don't face.
Correct. Since the pump uses only rapid-acting insulin and there is no long-acting depot, any interruption, a kinked cannula, a detached infusion set, a battery failure results in rapid absolute insulin deficiency. This can lead to DKA within just a few hours. Pump users require meticulous monitoring, routine site changes, and must always carry backup long-acting insulin pens.
And the pinnacle of current technology is the sensor-augmented system, often called the artificial pancreas. This is truly the future.
This system represents the tight linkage between CGM data and the insulin pump, governed by sophisticated control algorithms. The system receives real-time glucose readings and autonomously adjusts the basal insulin delivery.
And the most impactful safety feature:
the low glucose suspend function, which automatically stops insulin delivery when impending hypoglycemia is detected. This leads to a substantial reduction in severe hypoglycemic events. This technology is transformative, allowing many type 1 patients to achieve excellent control, particularly overnight, with minimal user intervention.
Finally, we must briefly touch on the use of variable rate intravenous insulin infusion, or VRII, strictly a hospital-based therapy.
VRII involves infusing soluble insulin intravenously. Because intravenous insulin has a very short half-life, it allows for immediate rapid adjustments to glucose levels. This makes it ideal for acute settings like perioperative management, critical illness, or when oral intake is compromised. It mandates continuous, hourly glucose monitoring and standardized protocols because, given the short half-life, any interruption in the drip can lead to rapid hyperglycemia.
And the final crucial clarification: why must VRI protocols not be used for DKA or HHS treatment?
DKA and HHS are defined by profound fluid and electrolyte derangements. Their primary treatment requires specific, life-saving protocols focused on fluid resuscitation and carefully titrated electrolyte replacement, especially potassium, alongside insulin. VRII is simply a glucose-lowering tool and does not account for the complex, acute metabolic needs of DKA or HHS. Those require dedicated, structured protocols that prioritize stabilizing volume and acidosis first.
So this deep dive has spanned the cellular pathology all the way to the highest technology. I think we've confirmed that mastering diabetes requires understanding two fundamentally different diseases.
It does. Type 1, the absolute loss of beta cells through autoimmune destruction, demanding exogenous insulin. And type 2, the progressive failure of beta cells to overcome persistent peripheral insulin resistance, requiring a multi-drug approach.
And we now have a set of anchors to hold this vast knowledge: glucokinase as the specialized beta cell sensor, the GLUT4 transporter as the insulin-dependent door, and HbA1c as the 120-day photo album.
An album which can be distorted by changes in red cell lifespan.
Right, and we solidified the crucial distinction between DKA, the car running on toxic acidic emergency fuel, and HHS, which spares ketogenesis.
Ultimately, diabetes care is a continuous exercise in risk management. It's balancing the push for tight glycemic control to prevent that devastating microvascular damage with the equally critical imperative of preventing the life-threatening acute risks of hypoglycemia and hyperosmolar crises.
It's a constant balancing act.
It is, and requires integrating complex physiology, diagnostic tools like CGM, and the powerful yet risky management pharmacology available today.
So, as you continue your journey as a learner in medicine, what does this constant balancing act suggest for the future? We discussed how targeted genetic diagnosis in rare forms like MODY and neonatal diabetes can completely transform treatment, allowing patients to stop insulin and switch to oral sulfonylureas.
A true revolution for them.
It is. So, given the massive, accelerating global epidemic of type 2 diabetes, a condition driven primarily by the intersection of genetics and environment, what singular genetic or environmental discovery, one that has a magnitude of impact similar to the original discovery of insulin itself, do you believe is most urgently needed right now to halt the tide of this public health crisis? This is a fundamental question to mull over as you transition from learning the mechanisms to applying the treatments.